بسم الله الرحمن الرحيم. رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقه قولي. During this presentation we will discuss premature rupture of membranes. Normally, bag of full water usually ruptures late in the first stage or early in the second stage. Exceptionally, early or late rupture of membrane may occur, or artificial rupture of membrane may be done. Early rupture of membrane means that bag of full water ruptures 2 hours or less before onset of labor. In other words, rupture of membrane may be the first sign of labor. In late rupture, bag of full water ruptures as late as end of the second stage. Artificial rupture of membrane or amniotomy is a minor surgical procedure done for induction or augmentation of labor. Premature rupture of membrane and preterm premature rupture of membrane are rupture of fetal membranes 2 to 24 hours before the onset of labor. Prom and pre-prom are rupture of fetal membranes with leakage of amniotic fluid in absence of uterine activity. Prom is spontaneous rupture of membranes prior to the onset of labor after the 37th week. Pre-prom is prom after the 20th week and before the 37th week of gestation. In absence of any intervention, 70% of patients with rupture of membrane will start labor within 24 hours, and 80% within 48 hours, and 95% within 96 hours. Rupture of membranes occur in 8% of term pregnancies after 37th week, and 3% of all deliveries before fetal maturity. The latent period is the time factor between onset of rupture of membrane and onset of labor. Its duration varies according to the gestational age. It is about 1 week in 50% of cases of gestational age 26 and 36 hours in 50% of patients at 32nd week of gestation and 24 hours in 75% of patients at term. Premature rupture of membrane may be due to direct or indirect causes. Direct causes include genital infection, trauma, increased intrauterine pressure, malpresentation and malposition, cervical incompetence, premature labor, congenital weakness in the amniotic membrane affecting its tensile strength, and also it may be idiopathic. Indirect causes are the risk factors for premature rupture of membrane. These risk factors include history of previous premature rupture of membrane, history of preterm labor, smoking, low socioeconomic status and malnutrition, bad local personal hygiene, and uterine congenital anomalies. Premature rupture of membrane can be diagnosed by history, examination, and investigation. History taking may reveal presence of one or more of the risk factors. Complaint of watery vaginal discharge, which is usually sudden and or excessive. Watery vaginal discharge may be in the form of leakage in dribbles. In such cases, stress urinary incontinence must be excluded. Abdominal examination may reveal fundal level less than period of amenorrhea, increased uterine tonicity, and fetal pools are easily palpable. By vaginal examination, you may find escape of watery fluid from the vaginal orifice, with the characteristic odor of amniotic fluid. The definitive diagnosis is by sterile speculum examination with observation of leakage from external os or presence of pool of amniotic fluid in the posterior fornix. During vaginal examination, you must exclude cord prolapse. Digital examination must be avoided unless the patient is thought to be in established labor, because it may result in increased incidence of chorioamnionitis, postpartum endometritis, neonatal infection, and shortening of the latent period before onset of labor. This slide demonstrates the effect of vaginal examination on the latent period at different gestational ages. Investigations needed for premature rupture of membrane are vaginal swab for culture and sensitivity, nitrazine paper test, Ferning test, Nile blue sulfate stain, alpha fetoprotein, lecithin sphingomyelin ratio and phosphatidylglycerol, evaluation of fetal well-being, amniotic fluid volume by ultrasound. Fern test is done by leaving amniotic fluid to dry onto a glass slide and then examined under microscope. Ferning is not more reliable than basic history and examination due to high false positive and high false negative results. This slide shows Fern plant to the left and Ferning pattern under microscopy to the right. Fetal complications of premature rupture of membrane include premature labor and respiratory distress syndrome, neonatal pneumonia, lung hypoplasia, cord compression and chronic fetal distress, cord prolapse and intrauterine fetal death, skeletal fetal deformities. Maternal complications include chorioamnionitis and puerperal infection. Prophylactic treatment of premature rupture of membrane includes treatment of bacterial vaginosis and other genital infections, cervical cerclage for cervical incompetence, rest in multiple pregnancy and polyhydramnios, avoid direct trauma. This photo demonstrates the procedure of McDonald operation for cervical incompetence. This photo demonstrates Schroeder operation for cervical incompetence. For management of cases of premature rupture of membrane, avoid vaginal examination for risk of infection. Exclude cord prolapse by sterile speculum examination. Take high vaginal swab for culture and sensitivity. Estimate the gestational age and assess fetal maturity. If gestational age is more than 34 weeks, termination of pregnancy must be done. If gestational age is less than 34 weeks, conservative line of treatment is adopted. Conservative line of treatment for cases of premature rupture of membrane include complete bed rest, maternal observation for chorioamnionitis, prophylactic antibiotics, corticosteroids, and tocolytics. Termination of pregnancy is indicated if pregnancy beyond 34 weeks, fetal distress, signs of chorioamnionitis, proved fetal lung maturity. Thank you for your attention. All good wishes and good luck.